Hi, my name is Jenna Leskovec. I'm presenting on case study 1, acute myocardial infarction. So acute myocardial infarction originates with coronary artery disease, where cardiac blood flow is affected by plaque buildup in coronary arteries. Over time, unstable plaques may fissure or rupture, creating a thrombus. Acute coronary syndrome encompasses unstable angina and STEMI itself. For the purpose of this case study, we'll focus on STEMI, which is the total occlusion of a coronary vessel leading to ischemia. It's diagnosed based on EKG changes and serum biomarkers. An acute MI is the ischemic death of myocardial tissue brought on by atherosclerotic disease of the coronary arteries. A blockage stops oxygen from perfusing an area of the heart, which leads to the chest pain, diaphoresis, and other symptoms of heart attack. The extent of infarct depends on the location and extent of occlusion, as well as things like duration and metabolic needs of affected tissue. It can involve the endocardium, myocardium, epicardium, or any combination of these parts of the heart. As a result of loss of perfusion, aerobic metabolism becomes anaerobic, and the affected tissue becomes unable to sustain normal myocardial function. Time is muscle. This is a common phrase heard when discussing STEMI. 60 seconds from onset, you're already losing contractile function, changes in cell structure. Minutes from onset, ischemic areas cease to function. 40 minutes in, there's irreversible cell damage. And 20 to 40 minutes after ischemia, there's necrosis. 1 hour after ischemia, there's microvascular changes, and there's an increased risk of pump failure. So from onset or recognition of symptoms, one should activate EMS or call a code. You want to obtain an EKG as soon as possible, and the thrombolytic agent or PCI should be initiated within 60 to 90 minutes from onset, sometimes called the door to balloon time. It's diagnosed using an EKG. Serial 12-lead EKG should be obtained within 10 minutes of arrival at the ED. The repolarization phase of the T wave and ST segment is usually the first to appear changed on the telemetry strip. Ischemia changes the action potential, resulting in the noticeable ST elevation. The affected leads indicate what part of the heart is impacted. Serum biomarkers are another important component of diagnosing an acute MI, but you should never delay treatment because you're waiting on blood work. The cardiac-specific troponin is an enzyme that enters the blood when the tissue becomes necrotic. Levels rise within 3 hours of onset. CKMB is an enzyme specific to injury of myocardial tissue, and levels rise within 4 to 8 hours. Clinicians should use troponin for diagnosis and establishing treatment. The goal of managing an acute MI is to reperfuse the heart. Initially, an unstable angina and STEMI are all treated the same. Traditional thinking is the acronym MONA, which stands for morphine, oxygen, nitro, and aspirin. Morphine was given for pain and anxiety, oxygen to maintain arterial levels, nitro to relieve pain and vasodilate, and aspirin as an antiplatelet agent preventing rethrombosis. Research suggests MONA is not always best practice. ACE inhibitors and beta blockers are also indicated in initial treatment. The three primary forms of resolving acute MI are fibrinolytic therapy, percutaneous coronary intervention, or PCI, and coronary artery bypass grafting, or CABG. Fibrinolytic therapy is dissolving the clot with drugs. These may be alteplase, TPA. Patients must be low risk for bleeding, and it's best done within the first 30 minutes after onset. PCI can refer to percutaneous transluminal coronary angioplasty or balloon angioplasty. It can refer to stenting, atherectomy, and thrombectomy, where the clot is either broken up or carved away from the arterial wall. And CABG refers to surgical revascularization of the affected myocardium by placing a saphenous vein graft between the aorta and the affected coronary artery, bypassing the occluded area. It's indicated for failed PCI or for people who are not candidates for PCI or fibrinolytics. Now for the case study. Mr. WG is a 53-year-old white male. He says he had pain in chest. It went up and down his left shoulder and arm. He describes it as worsening, crushing 9 out of 10 chest pain that started during physical exercise. There's no change with deep breathing. He's having a hard time catching his breath. He felt nauseated and sick to his stomach. EMS was called and he arrived at the emergency department within 30 minutes of onset of chest pain. EMS provided aspirin, morphine, oxygen, IV fluids, as well as 3 sublingual nitro, which had no effect. His medical history is significant for ulcerative colitis, poorly controlled high blood pressure. He's a diabetic. He has a prior acute MI with cardiac cath and balloon angioplasty 5 years ago, as well as chronic stable angina for 4 years. He has BPH, hyperlipidemia, colonic polyps. He's a 40-pack year smoker and 2 beers a week drinker. His family history includes his father was dead at age 55 from a heart attack. His brother has high blood pressure and his grandparents have heart disease. Upon physical assessment, WG reports exertional angina for the last 1 month. He has high blood pressure and he's tachycardic. His EKG shows 4 mm ST segment elevation and leads V2 through V6. His skin is cool, diaphoretic, and pale. His chest is non-tender, however there are slight bibasilar inspiratory crackles, and his chest x-ray shows bilateral mild pulmonary edema. His heart is tachycardic with occasional premature beats. He has a normal S1 and S2 and a soft S4, further supporting evidence of acute MI. Extremities exam yields distinct bruit over left femoral artery. His laboratory blood test results were obtained 3.5 hours post-acute MI. Notice he has hyperlipidemia, he has poorly controlled diabetes, and most significantly, his troponin is elevated. So Mr. WG was found to have no contraindications for thrombolysis, so he received IV retelplase, IV heparin, metoprolol, and lisinopril. 90 minutes after IV fibrinolytic therapy initiation, his chest pain and ST segment elevation resolved. He was stable for 2 days until chest pain began again. He underwent PCI, which revealed 95% obstruction in his left anterior descending coronary artery. After balloon angioplasty and stenting, he had an infusion of a medication for antiplatelets, and he was discharged 8 days post-MI. Question 1. Cite at least 6 risk factors that predispose this patient to acute myocardial infarction. He had a prior MI, he had hyperlipidemia, he was hypertensive, he was overweight, he has a family history, he's a cigarette smoker, he's a diabetic, and he's a middle-aged man. Question 8. Are there any indications that this patient needed oxygen supplementation during his hospital stay? An initial ABG was normal. However, WG was complaining of inability to catch his breath, and he received supplemental O2 from EMS. Based on symptoms, he was a candidate for emergent O2 treatment. Once at the hospital, however, his ABG could have been inaccurate because he received the supplemental therapy. STEMI patients may experience a sudden drop in arterial oxygen, and supplemental O2 is thought to help patients maintain those levels. WG has mild pulmonary edema from his MI. While the oxygen will not resolve this, it may help until fluid overload can be resolved. Question 9. Cite 4 clinical signs that suggest that acute MI has occurred in the left ventricle and not in the right ventricle. He has bilateral pulmonary edema and bibasilar crackles. These are symptoms of left-sided heart failure. His EKG shows changes in leads V2 through V6. He has an absence of JVD and no pedal edema, which would be signs of right-sided heart failure. And he's tachycardic and hypertensive. Question 10. Which single laboratory test provides the clearest evidence that the patient has suffered acute myocardial infarction? The answer is troponin. Question 13. What is the pathophysiologic mechanism for elevated temperature that occurred several days after the onset of acute myocardial infarction? Fever is part of the response to myocardial damage. There's an acute inflammatory process that develops in the area of necrosis. Neutrophils, monocytes, and macrophages respond and synthesize various cytokines like interleukin and tumor necrosis factor. These enter systemic circulation and they reach the hypothalamus, which is responsible for body temperature. The cytokines induce prostaglandin E2, which is an important part of fever development. Overall, fever is common. It can show up as early as 4 hours and resolve by the 4th or 5th day. Current research findings support the idea that the acronym MONA be considered obsolete. 2 studies in particular. One looked at morphine. There's inconclusive research on the effect of morphine on antiplatelet drugs. In one recent study, they found that morphine administered along with an antiplatelet medication decreased the plasma concentrations of the active metabolite of the drug, but didn't inhibit its effect on platelets in healthy volunteers. It was not tested in actual STEMI patients, but it is significant that the morphine is impacting the drug in some way. In regards to oxygen, the assumption has always been that having higher levels of oxygen reduces the infarct size as well as the patient's pain because you're reducing demand. However, a recent trial titled Determination of the Role of Oxygen in Suspected Acute Myocardial Infarction found that supplemental oxygen did not improve pain or survival, and they do not recommend oxygen for those that are not hypoxic. Another interesting area of current research is considerations for STEMI management in the era of COVID-19 regarding treatment of patients, suspected COVID-19 patients, or really anyone coming to the hospital who could be asymptomatic. So there's a potential for delay from first contact in the emergency department to PCI due to resource allocation, PPE shortage, all the different containment measures that have to occur, and current research supports the finding that there has been a delay. The delay is shifting to an increased use of fibrinolytic therapy for STEMI versus the immediate use of PCI, which would require staff to gown up in the cath lab. And further, there's greater need to evaluate risk of whether or not that patient may end up needing CPR performed in the cardiac cath lab. So staff have to prepare for the increased aerosolization that comes with CPR that would put them all at risk. So they have to weigh that risk a little more carefully than they did before the pandemic. And these are my references. Thank you.